بسم الله الرحمن الرحيم. يعني أنا مش قادرة أقول لكم قد إيه أنا مبسوطة بوجودي معاكم النهاردة. بشكر الأخ العزيز أستاذ دكتور إيهاب سالم على الكلام الجميل اللي قالوا عليا كتير عليا، وأنا اللي اتشرفت وأنا اللي سعدت. ويعني طبعا حتى لو جاية منين أنا يسعدني ويشرفني إن أنا أجي على طول على هنا وأبقى موجودة مع حضراتكم. طبعا منمن حبيبتي دكتورة منى كارم أختي الصغيرة، وما شاء الله شاطرة وطموحة وواجهة جميلة برضو الواحد يفتخر بيها. بشكرك على التقديم يا منى، وحقيقي موجوده معاكم يعني بسعاده واتشرفت جدا بوجودي. بعد المحاضره الجميله بتاعت دكتور اسامه اللي هو عمل لنا ريفيو عن الاوبيسيتي ان جنرال، انا الحقيقه كل تركيزي هيكون عن الادوليسنت اوبيسيتي، لان حضراتكم هتلاحظوا throughout my talk ان احنا عندنا حاجات مختلفه شويه عن الادلت، واحيانا مش شويه احيانا كتير احنا بنبقى مور كوشس، والجايد لاينز بتاعتنا ممكن تكون مختلفه شويه. هتكلم مع حضراتكم على adolescent obesity updates on the diagnostic workup and management. زي ما حضراتكم عارفين pediatric and adolescent obesity is a growing global health problem. In 1975 there were 11 million obese child and adolescent. In 2016 it jumped to 124 millions. So this is a very fast rise. And there is a very high global prevalence of pediatric and adolescent overweight and obesity. You can see the figure is heroic. More than 340 million child and adolescent having obesity or overweight at the age of 5 to 19 years. Focusing more on the sex, you can see both genders have a very high prevalence of obesity, but it's more in girls. So I think you agree with me that in the global threat weighting area, obesity is taking the upper hand, even more than the global warming and more than the flu and other diseases. Obesity is a disease and is a threatening condition. And here you can see an article published in the Newsweek mentioning clearly that Arab children and adolescents are among the world's 10 heaviest children worldwide. And if you look at the bars in red, you can see that Egypt is among the countries having a very high prevalence of obesity after Saudi Arabia and after the United States and others. So we have a rank over the world, one of the top 10 countries with childhood and adolescent obesity. We all know the BMI status classification, and here I'd like to highlight a very important point. In children and adolescents, use BMI standard deviation scores or percentiles, and you can see clearly the definitions of obesity and overweight and its classes using either the BMI Z score or the percentile. Please don't use the BMI numbers in a child or adolescents. And this is very important differentiating point than adults. And here you can see the charts for the BMI standard deviation score for children and adolescents. And we start defining overweight starting from +1 standard deviation going up. And this is the definition using the BMI percentiles for age. Again, you can see the definition of overweight, obesity, class 1, class 2, and class 3 based on the percentile. Again and again, don't rely on the BMI numbers. For us in pediatrics and adolescents, it's nothing. We cannot rely on this in a growing child and adolescent. And this is a very big statement given by European Association for Study of Obesity, WHO, and Endocrine Society. Childhood and adolescent obesity is a disease and a health issue. It's not just a cosmetic problem, it's a health issue, simply because there are numerous comorbidities and life complications associated with adolescent obesity. Of course, the causes of childhood obesity are complex and multifactorial. And of course, there are a lot of factors incriminated in this. We have the genetic type of obesity, either single gene disorders, genetic syndromes, or polygenic obesity. Of course, endocrine obesity should be excluded if you have any obese, short child. This is very important. If the child is tall and obese, this is simple obesity. If the child is short and obese, exclude endocrinal disease, namely Cushing, hypothyroidism, and growth hormone deficiency. Another important information is that obese child will probably be an obese adult. And this is not only in the shape and the body mass index, but even more with the cardiometabolic risk factors, metabolic, psychological, and other complications. The child will take all of these through the childhood going to adulthood. And this is a study here showing that obesity at 2 years predicts the weight status at 35 years. And you can see here that an obese child will probably be an obese adult. And the interesting thing in this study is that even the degree of obesity was correlated to adulthood obesity later on. So morbidly obese child is going to be a morbidly obese adult. And not only obesity, we also see that features of metabolic syndrome are transferred through the lifetime. If an adolescent has got features of metabolic syndrome, these features are going to grow with time and will turn out to be an adult with the same and even more features of metabolic syndrome. Now, this is just an outline showing pediatric and adolescent obesity clinic at Ain Shams University, Cairo, and I was privileged to be one of the founders of this clinic in 2000. It's a once-a-week clinic. We see around 30 patients per clinic. We have a multidisciplinary team, and the sources of referral are local pediatricians and other Egyptian governorates. And this is our protocol for assessing a child and adolescent with obesity. We do a full clinical evaluation, history, examination. We investigate for the cause and exclude endocrinal disease. And of course, we investigate for comorbidities, as you see, lipid profile, fasting glucose insulin, HOMA, A1C, C-peptide, liver functions, exclude PCOS in girls, and polysomnography. And indeed, sometimes we collaborate with other genetics, hepatology, and bariatric surgery if needed. Now, let me start the scene by the story of this girl. This is a live case scenario from one of our cases at the pediatric obesity clinic at Ain Shams University. This is a 13-year-old girl who was born normal. She started to have progressive weight gain for 6 years. She has menstrual irregularities and hirsutism. She dislikes sports. She has interrupted sleep and breathing problems. Her father and maternal aunt are obese. Type 2 diabetes is present in her paternal grandma. The girl is very tall, plus 2.8, meaning that this is not an endocrinal disease. She has a very high BMI, and more dangerous, she has a high waist-hip ratio. This is abdominal obesity, which is a risk factor as well. She's in tenor stage B2, her systolic and diastolic blood pressure are high, and she has acanthosis nigricans, as you see. So this is the case that I'm showing you. And looking at the labs, the girl has a high fasting blood sugar, high insulin, the HOMA-IR is very high, the A1C is in the diabetic range, and the C-peptide is normal. And look at the lipid profile. The cholesterol is very high, the triglyceride, the LDL, very high, and the HDL is very low. And even the liver enzymes are very high. So what is the diagnosis? Simple obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, depression. A very sad, but unfortunately, a very common story that we see nowadays. And here you can clearly see that obesity is only the tip of the iceberg. This girl came to us because she is obese. She did not know that she has all these comorbidities, even type 2 diabetes when the A1C was very high. And this is the critical thing about obesity, the hidden part of the iceberg, which is even more dangerous than obesity itself. Simply because there are a lot of obesity comorbidities, not only the features of metabolic syndrome, but other life-lasting and handicapping complications like depression, cancer, gallbladder disease, apnea, osteoarthritis, stress incontinence, GERD, dysmobility, and more. And this affects the quality of life of those children, ending by a very poor quality of life. So I think you agree with me that there is a heavy economic burden of obesity, not only because the child is obese and not in good shape, but because of the long list of comorbidities encountered in those adolescents affecting the life and economic status of any country. So obesity predisposes to premature cardiovascular disease, and this is a very important link that we need to focus on. Chronic systemic inflammatory disease increases the epicardiac fat, causing accelerated coronary atherosclerosis, atrial dysfunction and arrhythmia, heart failure, and affection of ejection fraction. So look how dangerous obesity could be in an adolescent. So again, it's not only the shape and the appearance, it's a long list of long life complications. We all know that we have two types of obesity, either the apple-shaped obesity or the pear-shaped obesity. Which is more dangerous, the apple or the pear? Thank you very much. Definitely. The apple is more dangerous because this is the type of obesity which predisposes to metabolic syndrome, ending by cardiovascular risk factor. So please remember that abdominal obesity is the predictor of other complications of metabolic syndrome, regardless the BMI, because nowadays we see children having a normal or high normal BMI and they have abdominal obesity. Still, they are at risk of metabolic complications, even if they are not morbidly obese. And remember that visceral fat reduces insulin sensitivity and predisposes to metabolic syndrome as well. And these are the definitions of metabolic syndrome in children and adolescents. Remember, I'm speaking about children and adolescents. These do not apply for adults. We follow the definition of IDF. HDL less than 40, triglycerides more than 150, the waist circumference more than the 90th percentile, systolic blood pressure more than 130, diastolic more than 85, and a fasting blood sugar more than 100. So these are criteria for adolescents. We studied the frequency of metabolic disorders and complications in adolescents at our pediatric obesity clinic at Ain Shams University, and we found that non-alcoholic fatty liver disease was the highest, and also type 2 diabetes was more prevalent than what we expected. And we published this in Hormone Research in Pediatrics 2019. So you can see that the components of metabolic syndrome run in vicious circle, triggered by oxidative stress, endothelial dysfunction, autonomic nervous system, and a running cycle of complications goes on in the presence, of course, of genetic predisposition and environmental factors, leading to early mortalities and maybe early morbidities in these adolescents. Now, my question here is, who presses the start button for obesity comorbidities? Who is the triggering factor for all of this? Insulin resistance and long-standing inflammation is the root for all metabolic complications occurring in obesity, in adolescents, and in adult. So there is a state of obesity-induced inflammation triggered by visceral fat, increasing the tumor necrosis factor alpha, interleukins, increasing cardiovascular disease, and metabolic complication. So what happens is that the normal adipose tissue is converted into enlarged adipose tissue. There is a decrease in the anti-inflammatory cytokines, increase in the free fatty acids, and increase in the pro-inflammatory cytokines with the chronic inflammation associating obesity. All of these result in excess inflammation leading to metabolic syndrome. So again and again, it's a disease. It's not just a shape or excess subcutaneous fat going on. Now, focusing on obesity-induced type 2 diabetes, again, hypertrophy of adipocyte increases the leptin, decreases adiponectin, inflammation leading to insulin resistance and type 2 diabetes. We all know the normal insulin response. Simply, insulin triggers the cells to remove glucose from the blood. So what happens with insulin resistance? Insulin resistance, the cells are insulin resistant and they ignore the message sent by the insulin. So the insulin continues to go up and the blood sugar is disturbed later on. So looking at the pathophysiology of insulin resistance and type 2 diabetes in adolescents, a lot of factors lead to altered gene and protein expression, glucolipotoxicity, insulin resistance, beta cell dysfunction, and type 2 diabetes. But there is a sequence of events through which the beta cells pass through before the occurrence of type 2 diabetes. You can see that the beta cell at first is healthy, and then stressed beta cell with decompensation, impaired glucose tolerance, failing beta cell with a rise in the blood glucose, until there is total death and apoptosis of the beta cells, ending by type 2 diabetes. So this is how the curves go. You can see at first the insulin is normal. It goes up in the stage of insulin resistance. It goes down when the beta cells fail. And with the blood glucose, it's impaired in the stage of insulin resistance, and then it goes up when there is frank type 2 diabetes. So we pass through the stage of a normal function, pre-diabetes and insulin resistance, ending finally by type 2 diabetes. And here there are the three main foci that the child or the adolescent passes through: overweight, pre-diabetes, and type 2 diabetes. And you can clearly see the changes that occur in the level of insulin and glucose until a stage of type 2 diabetes is reached. So moving from insulin resistance to type 2 diabetes, this diagram clearly illustrates what happens. Look at the insulin. At first, it's going up in the stage of insulin resistance, and then it goes down. And the reverse with the glucose. At first, it's stable, impaired, and then finally goes up with the stage of type 2 diabetes. Now, this is another interesting research that clearly stated that childhood overweight is associated with type 2 diabetes in adulthood as well. So do we need to screen type 2 diabetes in child and adolescent? The answer is yes. We have to screen if the child is above the 85th percentile and if above the age of 10 years or started puberty. And you can see the criteria in the box on the left-hand side. And this is proposed by ADA Standard 2022. This is very updated guideline. Now, going through the road to type 2 diabetes, you can see that the road is normal in green, orange, we go to the pre-diabetic phase, and then diabetes, which is the red color that we have to stop at. And the question is when to consider type 2 diabetes in a child or adolescent, which is quite uncommon, but started to be common. When there is no islet cell antibodies, obesity, acanthosis nigricans, high C-peptide, or family history. And remember, the situation is not very easy in a child adolescent. Sometimes there is a degree of overlap with type 1 when we call it 1.5, type 1.5 diabetes in an adolescent. What about insulin resistance, the stage that lies between the diabetes and the normal? Sometimes we can rely on the fasting glucose insulin ratio, and a cutoff of 4.5 can be used, and a fasting insulin above 10 defines hyperinsulinemia in an adolescent. What about the HOMA-IR to diagnose insulin resistance? Again, it's not very accurate in adolescents like in adults, but a cutoff of 2.5 in prepubertal and 4 in pubertal defines insulin resistance in adolescents. Inflammation triggers hypertension in obese, and you can see there's increased leptin, low adiponectin, more inflammation, increased angiotensin, ending by hypertension. And the same mechanism applies to obesity-induced dyslipidemia. The visceral fat increases the interleukin-6 and tumor necrosis factor alpha, increasing lipolysis, free fatty acid, leading to more insulin resistance and atherogenic dyslipidemia. So there is a state of what we call the glucolipotoxicity, hyperglycemia, hyperlipidemia, causing inflammation, B-cell loss, type 2 diabetes, more and more dyslipidemia, and the vicious circle goes on. And this is the cutoff to diagnose dyslipidemia in children and adolescents. And this was proposed by the expert panel of National Heart and Lung Disease. And remember that this applies only to adolescents. It's not applicable in adults. And this is the frequency of hypercholesterolemia, triglyceridemia that we found in a research conducted at Ain Shams University, hypercholesterolemia in more than 20% of cases. What about obesity-induced fatty liver? Insulin resistance causes simple steatosis, fibrosis, ending by cirrhosis, another vicious circle. And the Journal of Clinical Endocrinology and Metabolism published a nice article recommending screening for adolescent obesity in case of diabetes, prediabetes, dyslipidemia, prehypertension, polycystic ovary, NASH, obstructive sleep apnea, and psychiatric problem. You have to screen for all these in any obese adolescent, because early diagnosis is very important to avoid further complication, mortality, and morbidity. Now, let's go back to our case. Remember the girl that I started with? How can we manage this case? Can you help me? The plan of management. We have a case of simple obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, and depression. Now, let's take it step by step. Of course, we all know the cornerstones of management: diet, exercise, behavior, family-centered intervention. I think we all know this. This is what we all know very well. But the question here, is there any novel options that we can apply for adolescents? The answer is yes. Which way shall we go? A lot of options have been emerging in adolescents with obesity. And I think that the speed of options is growing very, very fast. We have a lot of things to choose from. And our aim is to shrink the fat cells. And here you can see the guidelines published in the Journal of Clinical Endocrinology and Metabolism. When to consider pharmacotherapy and surgery? The answer is if there is continued weight gain in an adolescent with failed lifestyle modification for more than 6 months. And these are the diet recommendation: reducing consumption of fat food, the portion control, and increasing dietary fiber. So I think we need to eat healthy as a lifestyle, go for the green, and reduce the junk food. Encourage any form of regular exercise. And these are the recommendations for increasing the physical activity, 20 to 60 minutes, according to the tolerance, limiting the screen time, 1 to 2 hours, and reducing the inactive leisure time, like the computers and other screens. And the question here, do parents follow the recommendation? Unfortunately, no. They keep saying, we are trying, but they do not follow the recommendations. And this is a problem by itself. So let's go back to this girl. What's the suggested management? This girl has silent type 2 diabetes. She's an adolescent. Would you like to give which of the following as a treatment? Metformin and lifestyle modification. Who will vote for the first thing? Okay. Who would like to give basal insulin, metformin, lifestyle modification? Less. Who would like to treat as a DKA? No one. Yes. We do not need to treat as a DKA. She does not have DKA. Now, if you look at the guidelines proposed by ISPAD, clinical practice guidelines, you can see that this girl applies to this category. If the adolescent is asymptomatic and the A1C is less than 9 with no acidosis, You just need metformin and lifestyle modification. If the A1C is above 9, you will have to add basal insulin. And if there is acidosis, you treat as ketoacidosis. And what happened with this girl? Failed lifestyle modification for 1 year. We kept trying with this girl. We gave her metformin, lifestyle. She's not responding well. Do you think our case is a candidate for anti-obesity medications? Who will vote for giving anti-obesity? Okay. Some will vote for giving. I think the answer is yes. But we need to be careful in adolescent. It's not a very big yes. There are certain indications proposed by Endocrine Society clinical practice guidelines. After failure of intensive formal program of lifestyle modification, both limiting weight gain and associated comorbidities. So don't run just giving medication. We have specific indication. And it should be used by an expert pediatric endocrinologist and re-evaluate. There should be reduction in the BMI more than 4%. So these are criteria that we have to follow. And this is a list of the approved anti-obesity drug for obese adolescents. Again, this applies for adolescents. I'm not speaking about adult. Orlistat is approved by FDA and NICE. Phentermine above 16. Liraglutide, 3 milligram above the age of 12 years, approved by FDA and NICE. And again, there is a combination of phentermine and topiramide above the age of 12. And please remember, metformin is not an anti-obesity drug in adolescents. We only give it, and it's approved in children above the age of 8 years with insulin resistance, pre-diabetes, or type 2 diabetes. So don't give it as an anti-obesity drug. Now, another question. Can we try liraglutide in this girl? Yes or no? Thank you. Yes, we can. Why not? She has the criteria. Failed lifestyle. She is above the age of 12 years. Yes, we can try liraglutide in this girl. So what are the indications of giving liraglutide in obese adolescent? If the body weight is above 60, and of course, by far, she is above 60. She's morbidly obese and above the age of 12. You can see here an initial BMI corresponding to 30. Can I apply this to my child? No, this is only for adult. So in our indication for adolescent, if above 60 kilograms and above 12 years of age. So I cannot apply the BMI number for a child. Now, liraglutide increases satiety and reduces the hunger, and it influences all dimensions of appetite. It increases the satiety, the fullness, reduces the hunger and the food consumption. It has got good effect on the body weight from the brain. The pancreas improves the beta cell function, the cardiovascular risk, and endogenous glucose production is reduced. And this is an article showing an effect on type 2 diabetic adolescents on liraglutide. There was a significant reduction in the A1C, in the fasting plasma glucose, and in the BMI Z score. And the conclusion here in this article published in the New England Journal of Medicine, liraglutide up to 1.8 milligram per day, combined with metformin and basal insulin, was effective in improving glycemic control over 52 weeks in children and adolescents with type 2 diabetes with a tolerable safety profile. So let me mention that FDA approved liraglutide for pediatric patients with type 2 diabetes from the age of 10 years. But remember, the maximum dose is 1.8 milligrams per day. It's not 3, like anti-obesity medication. And you can see here, this was very recent in 2022. This is a very recent indication of liraglutide. And there are other pharmacotherapies here, metroleptin in those with leptin deficiency, set melatonin, melanocortin receptor 4 agonist, and you can see semaglutide, long-acting GLP analog, and exenatide. You can see all these new medications which are okay for children. And this is a very, very recent article, hot from the press. It was published 2 days ago when I was just looking through the internet when I was outside Egypt. it came across me. Once weekly semaglutide in adolescents with obesity. If you look at the date, it was published in the 2nd of November, 2022. Very hot from the press. Among adolescents with obesity, once weekly treatment of 2.4 milligram semaglutide plus lifestyle had a greater reduction of the BMI in adolescents with obesity as well. So this is another revolution in the field of anti-obesity medication in adolescent. You can see here that the BMI went down in those on semaglutide long-acting compared to others. So this diagram, I've added all the types of anti-obesity medications applicable to children, and you can see the progress that happened since 2003 until 2022, the current time that we are in. A very quick word on bariatric surgery. I will not go through it. The indication in adolescents is a BMI from 35 to 39 with comorbidities or above 40 with no comorbidities. Please take care that the adolescent should be post-pubertal and near the final height, obesity despite compliance, and you need an expert bariatric surgeon. Again, you have to balance this with the lifestyle. There are a lot of options that I'm not going to go through, but I need to tell you that the response to various options in obesity is really variable. My last point here, would you like to investigate for the menstrual irregularities in this girl? She has menstrual irregularities. Is this something important or not? Of course, this is very important. She's 13 years. What are the suggested investigations? She has menstrual problem. What would you like to do? Thank you very much. FSH, LH, estradiol. We found borderline impaired FSH, LH with normal estradiol. We found very high testosterone in this girl, and the rest were normal. And when we did a pelvic ultrasound, we found bilaterally enlarged ovaries with normal echogenicity and follicle 1 millimeter in diameter. So can I ask you, does this criteria by ultrasound fit with polycystic ovary criteria? Who says yes? Thank you very much. I'm very happy. Of course, it does not fit with criteria. Any adolescent girl and woman could have follicles in the ultrasound, but there are certain criteria to diagnose polycystic ovary. And these are the ultrasonographic criteria proposed by Ballon in 2003. More than 12 follicles, at least 2 to 9 millimeters in diameter, ovarian volume more than 10 ml. And let me tell you that this occurs in only 20 to 30% of cases of polycystic ovary. So you could find a girl with polycystic ovary syndrome and the criteria are not fitting by ultrasound. Which type of polycystic ovary? You can see here there are 4 types. The girl fits with hyperandrogenism and chronic anovulatory type, which is a very rare type of polycystic ovary syndrome. Of course, we know the vicious circle, genes, environment, interacting with adipocyte obesity, leading to ovarian hyperandrogenism and sex steroid excess hirsutism. Now, can I ask you a final question? Could liraglutide be a useful medication in this girl for the polycystic ovary? Yes or no? Who says yes? Thank you very much. Yes, it applies. We all know the targeted pharmacotherapy for polycystic ovary. This is the classical treatment that we all know. But what is the new? The new is that the GLP-1 agonist, liraglutide, could modify obesity, androgen excess, and reproductive function. And this is a research that tested the liraglutide, improving the markers of ovarian function in women with PCOS. It's not in girls, in women. So it improves the bleeding, decreases the testosterone, improves ovarian volume and the weight. But remember that liraglutide 1.8 is not yet approved in treatment of PCOS management. But for me, I've tried it with some girls and it had a good effect. So finally, I think we need to redirect the arrow this way. And remember, obesity is the tip of the iceberg. We have to dig for other features and complications associating obesity. And definitely, preventing childhood obesity will help in shaping the future and improving the future of our children and adolescents. And remember these numbers, 5210, 5 fruits and veggies, 2 hours or less screen time, 1 hour of activity, and 0 sugar intake. This is the general rule of a healthy lifestyle. And I think that we need a global obesity prevention project, all ourselves putting hand in hand to fight obesity, which is really a big mission that we need to work on. My final thoughts are childhood and adolescent obesity is a growing global health problem. Arab children are among the heaviest in the world. The prevalence of type 2 diabetes is higher than before. Inflammation is the root of most obesity comorbidities. The horizon of anti-obesity medications in adolescents is expanding and going very, very fast. And remember, obesity is the tip of the iceberg. I like this quote very much. Food is the most abused and anxiety drug. Exercise is the most underutilized antidepressant. Remember this. And again, obesity is a chronic disease. Obesity affects every aspect of people's life, from health to relationship. I believe so. So I think we need to put our hands together to fight the heavy wave of the growing childhood and adolescent obesity, which is really, really a great challenge for all of us. Thank you very much for your attention.